Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health, and I want to thank you for joining me, as always, to have your COVID questions answered live. You can use the hashtag AskDrArwady or put the questions directly into the box below on either Facebook or Twitter. Today is Thursday, January 20th, and as some of you know, we had a press conference yesterday where we did formally share that we have past the peak of the Omicron surge here in Chicago, and we got a lot of questions in about that, so I've pulled together some data that's going to walk through that. But let's start, as always, with our dashboard. So chi.gov/COVID is the dashboard, and you can see here graphically that we are seeing big improvements. We're averaging 2,819 cases per day, which, just to be clear, is extremely high. It is much higher than we were at the peak last winter, et cetera. But compared to where we were, it's down 50% from a week ago and even further from the top. And we got a lot of variations on the question of, isn't this just because people stop testing after Christmas? And I want to make sure people understand this, because no, it is not just that people stop testing after Christmas. And let me sort of talk through how we think about this. And then if you've got more questions on this, I'd love you to put them in, because making sure folks understand how cases and tests fit together with positivity is really important. The top line message is that if we're going to say anything about how a COVID situation is changing, you have to look at both COVID and you have to look at both positive cases as well as tests together, and the way we do that is positivity. So in this case, to talk it through, for example, in the last week, cases, meaning positive tests that are deduplicated, are down 50%. Tests are also down, but tests are down 21% over that same time period. And so if the outbreak were completely stable, cases would be down 21% and tests would be down 21%, for example. Or cases would be down 50% and tests would be down 50%. The way positivity works, remember what positivity is? It is actually the number of positive cases of all of the tests that are performed. And so this positivity rate is kind of doing that math for you in terms of comparing the percent of cases that are positive against tests performed. And so in the same way, if the cases and the tests, the amount they were changing were the same, the positivity would not change. But in fact, what we saw is that because cases dropped about twice as quickly as tests did, we saw the positivity, almost cut in half there. And so the reason why you never want to look at just cases or just positivity is that they reflect together what testing looks like. And it's just important for people to know, because you can get into a high risk status as defined by CDC, et cetera, just on positivity. If your positivity is high enough, it suggests that you are missing, quote unquote, too many cases. But you can also get in based on high cases if your positivity is within a certain range. So I hope that's clear, but please let us know if it's not. And I just want to be really, it's an essential point when understanding some of this. Okay, for the sake of time, I'm going to move right into some of these slides that address, again, some of the questions that folks have and just some of our regular updates. So first of all, get into slideshow mode. We are, the cases, test positivity, and occupied hospital beds, non-ICU, remain in that very high transmission risk, but they are all decreasing, which is good news. And then ICU actually has never gotten into very high transmission, which is good, or very high risk. It's remained in high, and it is stable. So good progress there, but a very long way to go to get back down into those, more moderate and lower risk. So in terms of how do we know this isn't just an artifact, there is not just one factor that we look at here. So first, the earliest indicator that we see in terms of progress is people being diagnosed with COVID in emergency departments. This has actually been quite predictive all along. It's one of the things we follow. This is off the dashboard, the part where, in terms of the reopening metrics, it's one of the things we follow. And actually, Chicago Emergency Department COVID diagnoses peaked back on December 27th in terms of individual numbers. And then the average peaked here sort of December 30th. And then you can see this very nice decline after that. It's always a little tricky right around the holidays because more people will go to the emergency department because their doctor's office might not be open, for example. But nevertheless, we continued to see the earliest sign of progress be here, and then a continued and very consistent decline down from a peak of 671 to currently still 132 every day, which remains in the high, the very high risk category, but big improvement. So then, typically after the emergency department diagnoses, which sort of represent people who are coming in to get care, they're concerned about their health, is some of this positivity in case numbers. And that actually peaked right at the beginning of January. So COVID test positivity peaked in the January 1-2 range at 19.4%, and it has been declining, as you can see, really nicely since then. Numbers remain high, but again, this is a consistent decline. And that, along with cases peaked January 4, and these again would go together. We know testing patterns get a little bit are just different around the holidays, and that's where we want to see these two together, but seeing that change at approximately the same time makes sense. We had 8,631 cases get diagnosed on January 4th, just in Chicago residents, by far the most we've ever seen. And today we're getting down to a quarter of that, which is very good progress, but again, does remain high. Then, remember, hospitalizations sort of lag after that, because when we are seeing an increase in cases, we know that there is typically, it takes some time to see those numbers stabilize. So not surprisingly, we are only just seeing the beginnings of some decrease there. The highest number of admissions was back on January 4th, but you can see compared to these, where you're seeing a very big decrease already, the hospital numbers are only just starting to downtrend. And this is new hospitalizations every day. Let me be very clear, there are still more than 200 Chicagoans being newly admitted every day with COVID-19 in this, like in Chicago. That's very high. Almost all of those folks are unvaccinated. This is not a level that is good. This is a level that continues to strain the hospital, but we would expect it to continue to stabilize and slowly decrease based on what we're seeing in the other metrics. But the risk remains high, especially for the unvaccinated. Our hospital census, remember, is all the people who are in the hospital with COVID, regardless of if they're a Chicago resident, regardless if they've been there for 1 day or 4 weeks. And we do have a little bit more than, we're averaging right now a little bit more than 1,400 patients in the Chicago hospitals with COVID. You can see here that has just started to plateau or come down. It remains much higher still than any previous month. And then those ICU, you can see, have also just started to flatten. And they are higher, but sort of more in line with where we were last year. And that reflects the fact that, thankfully, fewer people get seriously ill. But there are 300 people in ICUs, many on ventilators right now with COVID-19 and with the Omicron variant. And again, not all, but most of those people are unvaccinated. I also just wanted to give an update on the variants. So every week we've been sharing this graph, and I'll just remind you that this is surveillance for the whole Midwest, but we have seen our numbers in Chicago match this within a point or two each week. And you see that the very first Omicron case, here in Chicago was detected in that week. Each of these bars is a week moving forward, and you can see that purple starts to show up that week ending December 4th, and then it starts really showing up the next week and going forward from there. But we went from just almost the first few cases up to now over 99% of the cases are Omicron. And we saw that happen really over just 5 or 6 weeks, and most of it happened in about 4 weeks. Also very consistent with what was seen in South Africa, which is where this pattern was first. And again, these patterns hold true. Unvaccinated Chicagoans are much more likely to be hospitalized. Even just looking at Omicron, 5 times more likely to be hospitalized with COVID than unvaccinated Chicagoans, and that additional booster dose clearly provides added protection. This graph is showing in red just numbers. How many Chicagoans are getting hospitalized each week per 100,000 population among people who are unvaccinated in red, among people who are vaccinated but not boosted in light blue, and among people who are boosted. Are we seeing some breakthrough hospitalizations? We are, and we've talked about that and shared some of that data. It tends to be among people who are older with underlying conditions, but the people I do worry about the very most is that red line. And just to put a finer point on this, more than 99.8% of vaccinated Chicagoans have not been hospitalized with COVID-19, okay? 0.2% have, but 99.8% have not. And these vaccines continue to work very well. I obviously share the concerns for, where we've got kids who have been too young and where we have immunocompromised people for whom the vaccine, they don't have a stronger response, et cetera. And there are some breakthroughs, but overall, these vaccines continue to perform beautifully. If you look at deaths, it's even stronger. We are averaging, as you saw on the dashboard there, there's a little bit of delay in the deaths coming in just because the numbers are so high right now. But we're averaging somewhere in the 14 to 20 a day right now of Chicago residents dying every day from COVID. And this is the same thing. The red line shows you how many deaths we're seeing per 100,000 population. In the red line are unvaccinated Chicagoans. The light blue line is vaccinated and the dark blue line is boosted. And this, to me, is the most important thing because that red line is still very much on the way up, and unvaccinated Chicago residents just during Omicron 8 times more likely to die from COVID than vaccinated and boosted counterparts. And again, it was more than 99.8% of vaccinated Chicagoans have not been hospitalized. It's more than 99.9%. It's actually 99.98% of vaccinated Chicagoans have not died from COVID. And when we especially think about preventing these severe outcomes, being able to live with COVID, not overwhelming hospitals, that red line remains my biggest concern. Lots of questions and follow-up about child hospitalizations. All of this is on the dashboard, but just highlighting for you that if you click on cases, you can look at hospitalizations, deaths, you can look at it by age, race, ethnicity, gender. And this is just a screenshot of the child hospitalizations. You can see in 0 to 17-year-olds remains really very low at the bottom there. But look at that among 80 plus, very much going up. And you know what? Our 80 plus are not as vaccinated as they should be. It remains an area that we're lagging, and I'm worried about. Being over 80, followed by over 70, followed by over 60, are independent risk factors for hospitalization, and then where people are not vaccinated, it is compounded. The child hospitalization rates have come, they've been very low, again, for some context, but where we dive into this and sort of look at what has happened during this surge, even among kids, vaccination has been really important in terms of helping keep kids out of the hospital, even though the risk of going to the hospital is low, thankfully, among children. You see here that in the solid lines, and this really peaked over the kind of Christmas holidays, right? And then the hospitalizations also coming down very nicely, as we've moved back into school, et cetera. But you see that the solid lines here, this blue is 12 to 17-year-olds who are unvaccinated, and then the green here is the 0 to 4-year-olds who are unvaccinated. And I do really feel for those of you who have 0 to 4-year-olds, haven't had the opportunity to have them vaccinated, and we can talk a little bit more about that. But I do want to reassure you, these are coming down nicely, just as we've seen for others. But look what's happened, way down here, the risk, 5 per 100,000 children per week is very, very, very low. And sometimes people like to see how it looks graphically. So I just pulled the 5 to 11-year-olds here. And this is this is just numbers, not rates. This is all Chicago residents that have been hospitalized with COVID between the ages of 5 and 11 over the whole pandemic. So you can see each week, if you're seeing one little bar there is one 5 to 11-year-old hospitalized with COVID. And you can see last winter in the surge, we had a little bit of an increase there. There was one week where there were 7 5 to 11-year-olds hospitalized. That's still very low. It is lower than what we see for a lot of other diseases. But I will just note that almost all of even the 5 to 11-year-olds where the risk is low were unvaccinated. Everybody in red here is unvaccinated. There are 2 examples to date in the city of Chicago of vaccinated children between 5 and 11 being hospitalized. Typically that is kids who have a lot of these underlying conditions. But I just wanted to put that in some context because we did get a lot of questions about it. This is the national situation, still very dark purple. The whole country has remained on the travel advisory for the 3rd week in a row, and not just on the travel advisory, but very high COVID rates. So nationally, averaging 238 cases per 100,000 people. Illinois, a little bit below the national average and coming down, which is excellent to see. Chicago, well below the Illinois average and coming down, which of course we're pleased about. But all of these numbers, we want down under 15 daily cases per 100,000, right? And they remain very high. In terms of some of the other data, here's New York City. We've been talking to cities. This continues to be consistent with what we're seeing here. Internationally, in the UK, the same thing. You see cases coming down nicely, that flattening of admitted patients. And then nationally, this is from the New York Times, which is an easy place to look at this graphically. These are just the top states right now that are having a lot of the biggest outbreaks. Wisconsin is on that list, and you can see those red lines for each state are showing kind of what the case rates look like, and then yellow is hospitalizations and gray is deaths. And so different than prior surges, the cases are skyrocketing, many of them mild, whereas the hospitalizations and deaths are rising, but not in proportion. But Wisconsin, for example, one of the states right now with the biggest outbreak and no signs yet of plateauing. Vaccination rates are continuing to increase, well above the national average for kids and adolescents. We've crossed now 42% of 5 to 11-year-olds compared to 27% nationally have had that first dose, and 76% of 12 to 17-year-olds compared to 65% nationally. I remain very concerned. Look at this. 12 to 17-year-olds and 18 to 29-year-olds are now more likely to have had a first dose of vaccine in the city of Chicago than those over 80. Like, that is very worrisome to me. So again, if you know anybody who's older, please give us a call. We would like nothing more than to bring them vaccine, answer all of their questions, do whatever is necessary. We do expect there is some missing data here, just because we got some specific questions about this. In particular, people who are vaccinated through the VA. There has been a separate sort of federal system around that. There is a lot of advocacy to try to pull that into some national data sets, but anybody vaccinated through the VA does not show up in these charts, but they also don't show up anywhere nationally. So in terms of that comparison, that's there. And then secondly, there may be some people vaccinated out of state in that older age group, people who maybe live in Chicago part of the year and live in other states, where still there is a lot of work behind the scenes to try to make sure that registries can appropriately share information while protecting privacy, et cetera. So we know it's a little higher than what we're seeing, but nevertheless, those behind the scenes data challenges are similar across the country, and we are well below the national average, and well below what we see for our youngest Chicagoans, adolescents, which is worrisome. So we also got some questions about what are we seeing in terms of vaccine uptick with the vaccination requirement coming into high-risk settings. Way too early to kind of have that full analysis done, but I did want to show you the data here. So since the winter holidays and implementation of the vaccine requirement, we've actually seen the biggest increase in first dose vaccine uptake, meaning people making that decision to get their first vaccine in 18 to 29-year-olds, which is great because that is a group that has historically been a little bit harder to, most 18 to 29-year-olds are healthy. They often perceive themselves to be at lower risk, but they also definitely want to be social and out doing things. And so that's a pattern we've seen in some other settings, and we're seeing early examples, here of a really nice uptick here. And thanks to 18 to 29-year-olds who are getting that done. Followed here by the 5 to 11-year-olds, not a surprise. They are still, relatively newly eligible, and, we're seeing good uptake there. But then next here are 30 to 39-year-olds. And again, what we might expect with that. In addition, where we look at vaccination by race and ethnicity, this is all ages. And so if you just look at adults, Latinx adults are now as likely as white non-Latinx adults to have gotten a first dose, which is good. Both lag behind Asian non-Latinx Chicagoans, and then Black non-Latinx Chicagoans are still where there is the most work to do. But since winter holidays, we have seen the best improvement, again, in first dose vaccination. So people deciding to get that first vaccine among Latinx in blue here, followed by Black Chicagoans, which has also been really good to see. And again, really glad to see those communities that have been hardest hit by COVID throughout, seeing some more vaccine and decisions, first-time decisions to get vaccine there. So as a reminder, lots of availability all over the city for vaccine, for boosters. This weekend, we've got plenty of signups available through the CDPH-sponsored family COVID vaccine clinics for kids, for adults, for boosters, whatever variation of Pfizer you want. Saturday at Richard J. Daley College, Sunday at Wilbur Wright College. Please go and register or give us a call, or you can always call for at-home vaccination. Just a nice graphic here where we've tried to simplify and be very clear about boosters. When should you get your COVID-19 booster? Anyone over the age of 12 should get boosted, 12 and up. You should get boosted 5 months after your initial Pfizer or Moderna series, or 2 months after your initial J&J vaccination. And then finally, we got some questions about the federal rollout of the rapid COVID-19 tests that are available. So yes, they are free. In case you missed this, you can order a test online at covidtest.gov. It actually went live, I think, while we were on Facebook on Tuesday, a little bit ahead of the official rollout. There is a limit of 4 tests to each residential address. You put in your information. They're saying they should ship them sort of within 7 to 12 days. They are prioritizing for harder hit zip codes. And just some more details here related to questions we got. To place an order, all you need to put in is your name and your residential address. You do not need to submit an ID. You do not need to submit a credit card. You do not need to submit health insurance information or any other information. You can share your email address to get updates on your order, like when it's shipped, et cetera, but you don't have to. So this is really meant to be just where should this test be sent? And anybody who is having difficulty accessing the internet or who needs additional support, you can call 1-800-232-0233. So again, this is sort of the first rollout of that for anybody rapid test availability. Really pleased to see that. It is also getting easier to buy these in the marketplace. They're more available on shelves in Chicago. And then finally, some good questions that I did want to emphasize. So you've heard me say a lot that right now during this surge, a positive test is a positive test. The positive predictive value of all the tests is really good. If your at-home test, if any of your tests come back positive, consider it a true positive. Stay at home for a minimum of 5 days. Isolate, inform your close contacts, etc. There is no requirement from CDPH to get a confirmatory test. I don't want you, if you've got a positive at-home test, thinking that you need to go and get a PCR, do something like that. There are some facilities, employers or schools or daycares, there may be additional documentation, but from a public health standpoint, in terms of what you should do to protect yourself and others, any positive test is positive. We need you to isolate for 5 days. And then for those next 5 days, days kind of 6 through 10, be extra careful. Be wearing your mask as much as possible, avoiding close contact with people who are high risk. The other thing, though, is that if you have a positive test and you have underlying conditions that put you at higher risk for hospitalization, if you are older, 60s, 70s, 80s. If you have certainly immunocompromised, but even, diabetes, some of the things that just can be of concern, we want you to talk to your healthcare provider right away when you get a positive test, because your doctor or provider will help you figure out if you should actually take medication, antivirals that can help decrease the risk after somebody is infected of them getting seriously ill, getting hospitalized. And there are IV versions. There's a monoclonal antibody. There's a medication called remdesivir. And there are now also some oral medications. And they are starting to be available in Chicago. We've worked hard with providers so that doctors know where to call. These are not something you can buy over the counter. You have to have a prescription. You have to be evaluated by a doctor. There's extra work that comes with them. But if somebody is high risk and they get COVID, whether or not they are vaccinated, if they have a breakthrough infection, but especially if they weren't vaccinated and they got COVID, please have them reach out, because it's too late to give those medications once it's been a week. And what our doctors are telling us here in Chicago is sometimes they've got people who have immunocompromised and are older and have all the risk factors, and they test positive for COVID, they're feeling okay, they sort of don't do too much about it, and then a week later they're really feeling badly and they're reaching out at that point. It's too late to give those prophylactic medications that help keep people out of the hospital. So just kind of this extra point on that if you're high risk, do reach out, because that's sort of a secondary, what we call secondary prevention. And the goal is to turn COVID-19 into something that doesn't put people in the hospital. And that is a newer thing in our arsenal around doing that, and I want people to know. So if you need a vaccine, a booster, you have questions, as always, chi.gov/COVIDVax or 312-746-4835, and let's take your questions. Thank you. Hopefully we got a good number of them, just going into some of that detail there. All right, Alexandria Deanne from Facebook. Now that we've reached the peak, as numbers keep going down, do you think the city will be lifting the vaccine requirement or restrictions? I have my wedding coming up soon, and I'm struggling with what to tell guests. So I want to be really clear about this. Do you think the city will be lifting it? Yes, the city will be lifting it at some point, for sure. We have not changed on that at all. When we get back down to that, there's 4 levels of risk as defined by CDC. The very high, the moderate, the low, which match up to the metrics that we follow here in Chicago. And when we get back down into that sort of moderate, low risk, we will not have the vaccination requirement in place, because the vaccination requirement is in place in high-risk settings, and that setting is especially high risk when the numbers are high, et cetera, et cetera. However, the timing of that, I don't know yet, because we are still, these first few days of decline, not first few days, these first couple of weeks of January have been really nice in terms of seeing some of that. But where this might sort of end, what will happen next, I can't fully predict it. I would not recommend trying to make plans around guessing when we will be sort of at that point for sure. If there's one thing we've learned, being humble around all things COVID makes sense. I can guarantee to you this will not, if your wedding is in January, these are going to be in place through January at a minimum. And I'm really, where we're thinking about this, I think it's more of as we move into spring and sort of see things kind of stabilize, know that our hospitals are back in good shape. There's a number of things that we're following here. But in terms of what to tell guests, I would, if it were me, I would be telling guests that they need to be vaccinated. Obviously, people will make different decisions. But in June, my hope is that we will be in a good place, but could there be another variant? Where could we be? I can't know for sure. But yes, the vaccine requirement is absolutely tied to how we're doing with the COVID outbreak, just as masks are. When we get like we were last summer, and we were able to have masks off, and we were able to not have restrictions in place, when we are in good control, that is how we will be in Chicago. But when we are not in good control, and particularly when we're threatening our hospital system, that's when we have to do things that help keep the risk down. Lisa Balde Veneria on Facebook. I keep hearing people say Omicron will mark the end of COVID. Is this a myth? If so, can you debunk it? Can you tell us what we can expect next? So the short answer to that is, and the honest answer to that is, I do not know for sure what is going to quote unquote happen next after Omicron, and neither does anybody else in the world. There are a lot of hypotheses that range from a best case scenario. A best case scenario would say this has been enough of a spread that we'll have enough people who have had protection, and that protection will be more long lasting. I don't think there is anybody in the world really who looks at this closely who thinks this will be the last variant. In a best, most rosy case scenario, future variants would be less virulent, less likely to make people sick, ideally less infectious, et cetera. But there is nothing that says a future variant could not also be more virulent, make people sicker, in a worst case scenario, not protect against those severe outcomes. I certainly hope that is not what is going to happen, but it would be irresponsible to say that that is not in the range. So we have sort of a best case and a worst case scenario. I feel very confident based on what we're seeing here and around the world that we are coming down nicely from Omicron. I'm very confident that those vaccines, particularly where people have had vaccination, a booster, and they've had recovered from COVID, right? All along, that is your best protection out there. We should be in a pretty good place, for a few months here. It would be my expectation, but COVID has not followed a seasonal pattern clearly at this point in the way influenza does. Really every 3 months we've been seeing surges. Nobody expected to see a Delta surge across the summer in the US, for example. So I expect, as we've seen with prior surges, as we sort of come down, there will be a period of relative control. And yes, we will move to be lifting restrictions and taking advantage of that. In a best case scenario, things would stay in very good control, but it is way too early to call that. So I wouldn't say it's a myth. It is a rosy outlook, and it is one of the options that would be a best case scenario. There are doomsday options out there. There are extremely positive. I think we'll probably be somewhere in the middle there. And we will learn a lot more as we come out of this Omicron surge. For me, it's not just what do the case numbers look like. Remember, there are these serology studies that we do, which are anonymous. They're done nationally, like across the states. It's coordinated by CDC, where people who are getting blood for other reasons or are donating blood, et cetera, in an anonymous way, you actually look at what percentage of the population has antibodies to COVID. And you can look and see, depending on the testing you run, like at a population level, you can actually see, are these antibodies from recovery of infection? Are these antibodies from vaccination, et cetera? And so, these estimates that we give you every month that are, before Omicron surge, we had more than 600,000 Chicagoans who had neither had a COVID-19 vaccine nor had any sign in their blood that they had recovered from COVID. I expect that number will be much lower. Between all the cases that we're seeing right now, additional work on vaccinations, kids being eligible. So it is good for us for that number to be lower. It tells us that more people have some level of protection, but that we don't have sterilizing immunity. Sterilizing immunity is if there's a way to completely stop the risk of COVID entirely, and we've not identified that at this point. So that's what I have to say. So Carla Marie Germany Wise on Facebook says, how can I trust you say we are reaching a peak, but you also say not to let our guards down now? You are giving a false sense of security. Yeah, thanks for that. This is tricky messaging. And the last thing that I want to do is give a false sense of security, which is why on all of those slides, as I was showing it, numbers remain very high. Risk remains very high. There are more than 200 Chicagoans getting admitted every day with COVID. We are not at all out of the woods. But have we reached the peak of Omicron? We have. And that's where sort of, I want to be, when I am providing information, my goal is to provide that information in a way that is up to date and unbiased. And if it is surprising, we present it in ways like I don't have any underlying agenda. So my agenda is to show clearly how we know that here in Chicago, we have reached that peak of Omicron, but the peak of Omicron just means that it's not getting worse, but it is getting better, but it is not better yet, if that makes sense. And so as we are coming down the other side there, knowing that the strain remains high on hospitals, knowing that those red lines of people who are unvaccinated continue to rise for deaths, for severe outcomes, knowing that we continue to see breakthrough infections, I do not want to imply at all that we can let our guard down. This conversation that I'm having about eventually being able to take the vaccination requirement off, eventually being able to take masks off, is that in our future? I absolutely expect that that is in our future. Is that in our future imminently? Absolutely not. I'm hopeful that sort of by the spring we'll be in that place. But again, we will continue always to make those decisions based on our local data here and the best knowledge that we have about COVID. And so if you have other suggestions about how to frame that, I want to be honest about the peak, but I don't want people hearing, if this is done, I can take off my mask, I don't need to get vaccinated, because the opposite, in fact, is true. And if we see people feel like I don't have to do any of these things, what we will see is we won't come down as quickly and as effectively. The hospitals stay full. It takes longer to sort of get to that point where we all want to get, where this is not the very high risk that it remains. Renee Harkey on Facebook. Can you discuss the effectiveness of the J&J vaccine and then boosted with a Pfizer dose? Will a third dose be required with J&J, or are you considered to be fully vaccinated with any version of the 2 doses? You are fully vaccinated with 2 doses if J&J is what you got first. Remember, if you're only getting 1 vaccine, J&J remains actually the best one to get. You got to get both for the primary series for Pfizer or Moderna. I think, honestly, if J&J had been a 2-dose series from the beginning, we might have had a different sort of outcome here. But regardless, your 1 dose of J&J plus your 1 dose of a booster, whether that is Pfizer, Moderna, or J&J, although we do recommend Pfizer or Moderna if you're getting a booster, but you can get J&J. You got 2 vaccines and you started with J&J, you are up to date with vaccination. Good question. All right, Regan on Facebook. I've been watching the dashboard every day in this latest surge, and I remember when the positivity rate was over 20%. Why is it that our peak seems to be below that? That's a great question. So this has to do with, it's a good behind the scenes question on how the dashboard works. Whenever a COVID test result is reported to the city of Chicago for a Chicago resident, which that happens no matter where they get tested, we report that test result out on the day for the day the test was taken. Why do we do this? Because it actually reflects the risk on that day. However, sometimes when we see surges and labs getting really overwhelmed, it can take longer for test results to come in. And so every single day we update the entire dashboard. So you will see quote unquote history change a little bit. And what we always see is positive test results typically get reported before negative ones do. Labs prioritize those need action on them, et cetera. And so it is not uncommon for us to sort of have a higher positivity, and then as the days come by and we're sort of seeing some test results that are coming in 5, 6, 7, 8 days, 9 days later, which is not at all what we want, but we do see a little bit of that. Those delayed ones more often are the negative ones, but whenever those come in, even 9 or 10 days later, that test result gets assigned to the day the test was taken. That is how you do epidemiology. And so when the state is reporting out, here's how many new test results came in, et cetera, that's like just how many results came in for the day. But when you're wanting to understand sort of the curve of this outbreak, you do want to put, and it's the same thing, when a death gets reported, it goes in on the day the death happened, even if it's taking the medical examiner with the number of deaths right now a little bit longer to get through those numbers. We don't add it, it doesn't show up the day the reporting comes through. We add it to the date of the death or the date of the hospitalization. It doesn't matter. And so that's why you will see that. So yeah, we were a little bit over 20% in real time, but as some of those delayed results came back, we ended just a little bit under 19%. I mean, sorry, under 20% for kind of the highest that we saw in this surge. And that's very consistent with what you would see if you looked closely at data in other places. And I can tell you're paying attention, so I love that. Yeah, so question here about sort of how are we following the surge, the numbers, et cetera, as more people are doing at-home tests. We've answered this a bit. I'm actually going to have Stephanie Gretsch, who is one of the epidemiologists at CDPH, one of our senior epidemiologists, who has really led on a lot of the reporting around vaccine during COVID, but also she leads the work in our immunization and vaccine preventable disease kind of data team. And she's going to come on early February, I think maybe February 1st, to talk more behind the scenes about how the dashboard works, and also how we do influenza surveillance, flu surveillance, because where we're moving long term here is I think it is probably going to look more like that. So we'll be talking a lot more about that when she comes on as a guest soon. Okay, Mary Cruz Torres from Facebook. Oh, this is a really good, I haven't talked about this yet. I hear that there's going to be a vaccine for children under 5, but it will consist of 3 doses. Can you clarify if this is true? All right, good. So let's talk about what is going on with vaccine for the youngest Chicagoans. There have been studies, as you know, for kids from 6 months up to the age of 4. And Pfizer, as they have all along, has been out in front in terms of the timing, the enrollment of these studies. And you might recall that late last year, I was saying that I was quite optimistic that we would likely have a COVID vaccine for those younger kids, at least the 2 to 4-year-olds, probably in the first quarter of this calendar year. However, when Pfizer actually did the unblinding, right? These studies are done in the same way that all vaccine and drug studies are done. You've got groups, you're comparing. All of the safety data for vaccines for these younger children looked fantastic. No problems with side effects, no problems with issues, nothing with safety. However, they had decided to use a very small dose, 1/10 of the dose of what adults get for Pfizer. And what was interesting is, and in the lab studies, et cetera, it had suggested that that would be sort of a good dose. And although that was clearly a fine dose from a safety perspective, what they saw in the study was that it didn't give the level of protection that you needed it to, specifically for kind of that 2 to 4-year-old group. It was actually better in the youngest kids, the 6 months up to 2-year-olds. Like in that age group, that dose, actually was working pretty well. But in the 2 to 4-year-olds, again, no safety issues, but the level of antibody response that we were seeing was just not what they were anticipating based on the prior lab work. And so they had a little bit of a decision to make here. We know that younger kids in particular very often require multiple doses of vaccines. Like children's immune systems just are developing differently than adults. The youngest kids, those kids under 6 months, their immunity really comes from whatever their mom had. So one of the reasons we really encourage pregnant women to get vaccinated is not just to help protect them, because pregnant women are at much higher risk for severe outcomes from COVID, but also if they have antibodies, some of that does get passed to their baby, and the same thing works for other diseases. That first 6 months, you could try, even if you wanted to sort of vaccinate a child, the immune system is still kind of using what it got from the mom. It's not starting to really build its own in the same way. But there are a lot of vaccines. Like some of the standard childhood vaccines that everybody gets are, 3, 4, 5 dose series, because that's just what it takes with these kind of kids that age sometimes to sort of get the protection that we need. And so Pfizer made the decision, talking to all of its pediatric experts' decisions, to actually stick with that same low dose, but add a 3rd dose with the same spacing, with the same follow-up. But doing that means that it pushes everything back by a number of months, because adding another dose with the appropriate spacing, following up for the, the months that are required after that, means that I don't think it's likely, unfortunately, that we're going to see a vaccine for that younger group, probably until more like the summer, probably until we're out of Omicron. And I know that's disappointing and hard for a lot of you who have younger children, but I also want to just state very clearly that it is, we never skip steps. We never cut corners in terms of approving and doing the studies on vaccination. And no vaccine ever gets approved, ever gets emergency use authorization, ever gets full approval, unless all the steps around safety, follow-up, and efficacy, how protective is it, are where they need to be. Those get predetermined. And, is there a lot of demand out there for vaccine for those younger kids? There is. Did the study show that it was ready in terms of giving the amount of protection that we want it to? It wasn't ready. So there is not now, nor do I expect that there will very soon be a vaccine yet for those youngest kids. It's going to be important to continue, doing the masking, doing those things. Obviously, for the 0 to 2-year-olds, that risk is lower. And thankfully, those youngest kids, again, it's very rare that they do get the severe outcomes, but I know it is worrisome to people. So I don't know if might we end up with a vaccine for kids under 5 that is just right from the beginning, sort of a 3-dose vaccine series? We might, but we don't know yet. And if that does not give the level of protection, they will need to go back and probably look at a slightly different dose, and that would delay it some more. So I know that's disappointing. Moderna is also doing some pediatric studies, but they're further behind. So that's what I have to update. And we will certainly keep you updated on that as there is good news or continued news out of those studies. Okay, so just trying to see what else is here. So Ricky Passy from Facebook says, question, why do people who test positive for COVID while dying from a gunshot wound still count as a COVID death? I've answered this question a lot, but it's worth talking about, I think, if there are still questions about this. So first of all, COVID deaths count as COVID deaths if the medical examiner certifies COVID as a cause of death. If somebody dies of a gunshot wound, this is not a quote-unquote COVID death. This has been complicated a little bit by the COVID hospitalization data. And let's go ahead and talk about that. So we have seen, because there are a lot more people who are vaccinated and boosted especially, or who previously had COVID and are having very mild infections, we are seeing more examples of people who don't know they have COVID, finding out they have COVID because they go to a hospital for something. They go to a hospital to get a test. They go to a hospital to get treatment. Hospitals, let me tell you, test people a lot. They will not do anything that is not emergent on folks without testing for COVID. And so there is a group of people who are hospitalized, a small group of people who are hospitalized and just kind of incidentally found to have COVID. There are also people who are hospitalized where COVID may be more of an exacerbating condition. What do I mean by that? Say somebody has COPD, chronic obstructive pulmonary disease. It's a common lung problem. Different things can sort of can make someone with COPD get into some trouble and have to get admitted to the hospital and get some treatment. COVID would be an example of something that if they got infected with, there's a decent chance someone with bad COPD, COVID could be part of what gets them hospitalized. In this case, a COPD exacerbation would probably be their primary diagnosis, but COVID would be a secondary diagnosis. So all of this gets looked at. if COVID is incidental, if it's not a primary, a secondary diagnosis, they're not getting, we do compare those out. But also, just to kind of understand what this means in practice in hospitals, if somebody has COVID, you actually have to treat them as a COVID patient because they are potentially infectious to everybody around them. There has to be separate PPE. You have to separate them. You have to do, there are those of you who have never worked in a hospital, there are a lot of extra precautions that come when a patient has the potential for spreading infection. And so in terms of the hospital bed that they take up, they still take up a hospital bed. And in terms of the COVID-specific resources, there are different COVID-specific resources regardless of the primary reason that they are in the hospital. So where our epidemiologists actually do follow up, especially on breakthrough hospitalizations, which we do want to understand. We're calling and talking to people. Did you have symptoms of COVID? We're looking at their hospital records. Was this the reason? There is a small percent, but 10% that will say, actually, I didn't know I had COVID, right? I didn't have symptoms. But most of the people, let me tell you, they know they have COVID and they are in the hospital for COVID. And in terms of the deaths, it is how the medical examiner certifies it. And if somebody dies of a gunshot wound, they die of a gunshot wound. So I hope that helps clarify some of that. I think sometimes that is a longer explanation, and often people don't have the time to kind of read the longer explanation or think about it. And so I do see it's an example of something where I think people will sometimes share things on social without all of the context that goes behind it. So if you're seeing somebody doing that, I would encourage them to actually read a little bit more about it. There's nobody trying to hide data on this. There's nobody trying to misclassify COVID. I wish there were lots of people dying not really of COVID, but there are. The people who are dying in Chicago that are being classified as dying of COVID are dying of COVID, and the medical examiner gets the final say on that. Angela Gostela from Facebook. You can't stop the spread. Why are you investing in masks? Oops. Why are you investing in masks when they haven't worked for 2 years and you're not investing in early treatments? You can treat COVID and yet the hospitals don't. It's criminal. We want answers. Okay, so a couple things on this. Number one, as I discussed on Tuesday, we cannot entirely stop the spread of COVID. I think regardless. However, can we significantly minimize and reduce the risk of the spread of COVID? Absolutely we can, and we do. Just during Omicron, people who are unvaccinated, forget the severe outcomes, which is where the vaccines really shine. Just in Chicago, twice as likely to be infected with COVID if you are unvaccinated versus if you're vaccinated. I still have not had COVID. I have had plenty of exposures to people at this point, as I know many of you had. I'm careful, of course, but I'm also vaccinated and boosted. And I think there's a sense that somehow with Omicron, we gave up and that we stopped being able to protect, whereas in fact, it is well over, the last time I looked at it, I think still well over 90%, I think it was 93, 94% of Chicagoans who are vaccinated have actually not had a COVID breakthrough infection. Now 7 or 8% among, that is a lot of people, but somehow this idea that the vaccines are not helping is just not based in data. They are not eliminating the risk of spread, but they are reducing it. You cannot spread COVID unless you get COVID. You cannot get COVID from getting vaccinated, and getting vaccinated is the most important thing, getting vaccinated and ideally boosted to help protect yourself. And then in addition, where we see people who are vaccinated and boosted get COVID, their symptoms are less, their time frame is shorter, their amount of time that they could be spreading is shorter. So for a whole host of reasons, getting vaccinated and boosted, although it is primarily about protecting me, it also is protecting the community. Masks, on the other hand, remember, are mostly, first and foremost, about protecting others. That's why everybody has to wear one. You do get, though, some additional protection for yourself if you are wearing a mask that fits your face well, that you are keeping it on, or that is, higher quality. And by higher quality, we mean multiple layers, fitting your face. And then if you find one that fits your face and you can keep on, these KN95s do increase a little bit your personal protection. The number one thing, though, remember, of a mask is actually about everybody wearing one and having that barrier. And so that's part of why we've got the vaccine requirement in place in indoor public settings, because you might feel fine. You're vaccinated, you're boosted. Why do I need to wear this mask? You continue to wear that, mostly for the people, you know, the children who haven't had a chance to be vaccinated, the people with underlying conditions, et cetera. But why have we distributed 1.5 million KN95 masks is because we were really hearing from folks and recommending that, you know, I want folks doing everything they can to protect themselves and others, of course, during the surge. Anything that helps decrease the risk, and wearing a higher quality mask is something that decreases risk. It's not the most important thing. Getting vaccinated and boosted is the most important thing. Staying home when you're sick is more important. Like, there are other things that are more important, but masks are important, and it's something that we can provide, and we're happy to do so. So that was a one-time distribution, but my message on this has not changed, and neither has the CDC's. You should wear basically the highest quality mask that fits you well and that you can keep on, and that's what we need people doing. So to the second part, though, and you know, it says, why are you investing in masks when they haven't worked for 2 years? They actually have worked. Again, are they as important as vaccines? They are not, but there have been studies, I've shared them on Facebook here, where they've looked in some other countries where masks are not available in some villages and they are in some, and done randomized trials. There's been really good studies comparing the risk in schools where there are masks in place and not in place. And it is clear that masks help. Are they the be-all and end-all? No. We have this Swiss cheese where you're sort of putting things in place. And still, if I get one choice, vaccine is it, but masks are important, and especially during a surge they are. So the second part of your thing, you're not investing in early treatments. You can treat COVID, and yet the hospitals don't. It's criminal. We want answers. So the second to last slide that I showed about what to do if you have a positive test is actually about that. As FDA has been authorizing new treatments that have good data behind them around helping decrease the risk for people who get COVID. Of course there's investment in that. Of course I want Chicagoans to access this. I've talked about some of this, you know, on here before, but to give you a sense, the monoclonal antibodies, the remdesivir, those are the IVs. You know, remdesivir originally was a drug that was actually only approved for people to get in the hospital, but it was our first FDA approved drug. We've been given that one since early 2020. But as more research was done, it's been expanded that it's now available in that earlier stage if somebody has just been infected and they're in the first few days of infection, because the data showed that if it can be a pain to go and get an IV. It's not appropriate for everybody. You got to see the doctor, all of this, but it helps keep people out of the hospital too. But then these oral medications, which yes, have arrived in Chicago, are growing. When we talk to our providers, they tell us, we have some of these treatments, you know, not a lot of them, it's new, they're growing, but they have more than they have been able to use. And so that's why I'm messaging some more that we really want you hearing. Like, if you hear somebody who, you know, if my mom were to get COVID, please mom, don't get COVID. But if my mom were to get COVID, she's older, she has underlying conditions, she obviously is vaccinated and boosted and being careful. My recommendation to her would be, call your doctor. You know, she's got a specialist, she's got a number of things going on. And my very strong assumption would be that her doctor would advise her to get either one of the IV or one of the oral treatments to help decrease the risk of hospitalization. And that is what I want people who are high risk in this city doing. Because this is like one of the most exciting breakthroughs we have, that we now have, you know, we haven't had a Tamiflu. Tamiflu, for those who don't know, is when people do get influenza, it's an oral medication that you can take for people who are high risk that helps keep you out of the hospital. It is not prevention in the same way that the flu vaccine is important for prevention, the COVID vaccine, but it's a secondary level. And so in the studies, like the most recent version of this, the Pfizer medication, which you do have to take over multiple days, it's multiple pills. This is not a sort of pop one pill. It decreased the risk of hospitalization for people with severe outcomes, et cetera, by like 85%. So let me tell you, we are working extremely hard to make sure that all of our hospitals and the outpatient providers linked to them, all of our federally qualified health centers know how to access these, and that when high-risk people, especially if they're not vaccinated, but even if they are, if they're vaccinated and boosted and they get a breakthrough, a big focus and a big part of the plan moving forward is making sure they have access. So, so I hope those are the answers that you're looking for. All of these things are important, and as new availability is there, we of course adopt that and work really hard to make sure people have access to it here in Chicago. Okay, as the very last question, I think Araceli Gomez Aldana has been tweeting this a fair bit. So should we be worried about a new variant? How does the city and state monitor new variants and their transmissibility? So that's kind of a bigger question, and we are also going to bring on the person who does our lab-based variant stuff soon to talk about that. But very high level, here's what happens. We collect random samples from across the city of like leftover samples of people who are diagnosed with COVID in clinical settings. So they're diagnosed in the hospital, they're diagnosed, we do that geographically because we know different hospitals have different capacity to do that testing. There is a program for doing this all over the US, but we have really built up the ability to do it in Chicago with new federal funding. We did not have the ability to do any of this, just to be clear, prior to COVID, but it's been a real focus of the health department. We have a program called the Regional Innovative Public Health Laboratory, which is about growing exactly this kind of capacity. Rush University is actually the partner that won the competitive award to be the primary lab leading on that. So we work really closely with the laboratory at Rush. They are running samples, on people from across the city, different demographics, et cetera, in a way that is randomized and representative. In addition, and all of that it takes a while to run those results. Those all get reported into databases that are shared regionally, nationally, internationally, all over the world whenever the genetic fingerprint is taken of a virus, of a variant, it gets uploaded. And so, in addition to that, if another large hospital, like for example, Northwestern, which has a lot of academic sequencing capacity, any patients that they are sequencing also get uploaded. This happens all over the country. And then all of that gets pulled into the data like I showed, if you weren't on for the first part. And that's where we're sharing these estimates of what percentage do we think are Omicron at this point. They are all Omicron, basically, 99% plus. So should we be worried about a new variant? I don't think we're done with variants. I don't think my money would not be on that we would see a new, very concerning variant very soon, just because Omicron has been so contagious and infectious and has outcompeted Delta and the others so fast, but Omicron came really quickly too. So am I confident that we have the surveillance in place to detect it? I absolutely am. And we will talk some more actually about the behind the scenes of that. Even remember I was saying we'll talk about how we do influenza. There are similarities there to what we will be doing in a long-term way to monitor COVID, even when things are calm and in a good place. So that is high level what we do. There are different studies that are done to understand, especially if there's a new variant, we do a lot of extra investigation around early cases of that to sort of understand how many contacts were infected. There's extra kind of attention on new variant cases, not just here, but around the world. And you're able to, from that, to kind of compare the risk between other variants, first in an outbreak kind of way, but then that becomes part of the larger system. And that's how I know, for example, that people are 5 times more likely to have gotten Omicron than they were any prior variant if they were just relying on prior infection as opposed to vaccine. All right, we are at noon. I hope this was helpful today. We will be back on Tuesday. We continue to update that dashboard every Monday through Friday around 5:30 or so you can keep watching. And please do explore. There's all kinds of stuff on there that I think people don't always recognize is there. And I love it when people ask data questions. So if you've got questions about that or the dashboard, put them in. And we will see you next Tuesday. In the meantime, back to the point of the person saying tempered optimism. Yes, we are past the peak. No, we are not out of the woods. And I encourage people, to take this with hope in terms of, yes, things are not getting worse right now, thankfully, but there's a long way to go until they are in a place that they are better and that we can be confident that our hospitals have space for everybody who needs care, especially with flu season and all of the rest of this. So thank you, and we will see you next Tuesday at our normal time, 11 Central. Thanks.